Okay, so this is still chapter 43, and now we're going to go over IBS. Again, not to be confused with IBD. IBS is different in that you don't have the same inflammation. All right, so irritable bowel syndrome, again, just irritable bowel syndrome and inflammatory bowel disease. All right, so irritable bowel syndrome, this is one. This is chronic. This is a disease. This is inflammation. This is a lot of times related to diet, stress factors, things like that. This they at least found like one positive gene that could predispose you to having inflammatory bowel disease. So I just want to point that out. Okay, so IBS. IBS is irritable bowel syndrome. Irritable bowel syndrome happens more often in women than it does men. And it's idiopathic. It doesn't necessarily have a cause, but it's basically an irritation of the bowels. And the irritation of the bowels has to do with either being either diarrhea or constipation. It is a chronic disorder. And it requires that you have a good relationship with your patient. You need to get all the information, all of the symptoms, and it might be sensitive for people to talk about. So making sure that you have that good patient relationship. It's a chronic disorder of irritation of the bowels. Its symptoms are going to be obviously pain, distension, bloating, flatulence, nausea, vomiting, diarrhea, sensation of incomplete evacuation. Right? No organic cause. But they have traced the contributing factors, and a lot of the contributing factors have to do either with nutrition or with psychological factors. So those are some contributing factors for irritable bowel syndrome. So especially when we're looking at nutrition, we're looking at our saccharides, which are sugars. And of those sugars, you have OG, which is a few sugars. Di is obviously 2. Mono is obviously not 2, it's 1. And then sugar alcohols, which are those are your sugar alcohols. So that's when we're trying to eat low calorie food, we end up with sugar alcohols, especially processed food. As far as your psychological go, you're looking at stress, PTSD, depression, abuse, as some of your factors set. All right. So again, it's idiopathic. You're looking at nutritional and psychological factors as being things that we need to assess and treat. And there's not a specific, and again, because this is idiopathic, there's not any really specific tests you can do for this. It's really a matter of ruling out other things and making sure that there's not other things going on with the patient. There is Rome criteria. Rome criteria basically is it's called Rome 3 criteria appropriately. If you have 3 and 3. So basically, if you have symptoms more than 3 days out of the week for 3 months, and you can't figure out what else it might be, then you have IBS. The diagnostic studies that you might look at here you're still going to look at your CBT, but family history, your ADLs, level of activities, diets is going to be important. We need a log. And then your psychological, what's going on with your affect. And with these 3 days for 3 months, we're looking at several different factors here. It's going to be relief on defecation. So they feel better after school appearance, and frequency changes. So again, IBS, your bowels are irritated. No specific test you can run, no specific cause. Look at nutrition, look at activities, look at stressors. So our treatment is of course going to focus on the symptoms because I can't focus on the disease. So we're looking at your dietary fixes. We want to increase fiber slowly. Heck, if you increase fiber very quickly, you're going to have issues. Alright, so increase fiber slowly, 20 to 30 grams. You want to look at those psychological factors. Again, INOs, all over the place. INOs, avoid flatulent foods, because like I said, flatulence is one of the issues, and that's going to cause distension, that's going to cause pain. So you're pretty much your green leafy vegetables, broccoli, cauliflower, cabbage, things like that. You can also look at some of your caffeine and stay away from those sugars, which, especially sugar alcohols, can cause issues. Probiotics might be, and if they have, a lot of times patients that have IBS have other nutritional allergies. So looking at, well, maybe you're never been diagnosed as lactose intolerant. Maybe you became, maybe all of a sudden you have an onset of celiac disease. Things like that happen, so you need to look at those components as well. And of course, take out the lacto, or again, maybe it's celiac disease, which causes a lot of similar problems. So taking out your wheat, things like that, for celiac disease. So some of the drugs that, and again, stress management, if I haven't said that already, because there is a psychological factor here. And of course, if they're in an abusive situation, it doesn't get better with time. So some of the drugs that we're going to use here is Imodium. And again, it can be diarrhea or constipation. A lot of times we try and treat diarrhea and end up with constipation. So it's really best to increase your level of activity and nutritional aspects. But Imodium, aldosterone is only used, it has an extremely high rate of constipation, and this is like a last resort. The progesterone for women, selective calcium blockers, which was kind of surprising to me, but a lot of the things that I looked up said that they would help with the pain related to that. Lactolide, this is for men and women. Now, I can't say that I actually understand why one is just for women, but that one is for men and women. And then chloride, calcium channel activators. We're trying to activate chloride activators, and that's going to increase your motility. And then tricyclic antidepressants. So again, we are treating the symptoms, not the disease. Dietary changes, of course, are going to be important. Increase that fiber, decrease that the fake sugar. Stay away from that. Your fructose, or the fruit sugars, lactose, milk products, gas-producing foods, especially those sugar alcohols. So those are going to be your main things there. Of course, you want to monitor those INOs and make sure that they're not getting dehydrated. That's going to be important, as well as constipation, which could lead to obstruction. Again, better to fix the diet and the activities of daily living than start somebody on more medication, which has more side effects. Okay, so diarrhea, let's look at that real quickly. So this is usually viral, as you might imagine. We have bacteria causing these, of course, E. coli, our famous one, C. diff. It could be a parasite. The tests you're going to run for this are similar to any other one. You want to run a stool, check your white blood cells. You also want to check for fat in the stool, which indicates a decrease in the function of the pancreas. Some of your drugs you can use are, of course, antidiarrheal, Bismuth, and Imodium. You can also use your bulk-forming laxatives for diarrhea. Again, monitoring those INOs. If it gets very severe, then you can go into a hypervolemic situation. But again, monitor those INOs, making sure their vitals are good. Fecal incontinence, which is the other spectrum. Fecal incontinence can lead to obstruction, which is going to be pretty bad because that leads to issue and leads to death. So fecal incontinence means that, oh, I'm sorry, I got ahead of myself on the obstruction. Anyway, fecal incontinence, involuntary passage of stool. And this has a lot of reasons. So this could have been from a stroke, this could be neural, this could be psychological, this could be lack of muscle tone, trauma, childbirth, also pelvic floor dysfunction, and then of course your physical impairments, your functional aspects of it. So the foods that can cause diarrhea, nutrition-wise, we have onions. I didn't realize that. Dried fruit, spicy food, and gluten. Some of the other things you need to watch out for is that sugar alcohol, because in high content it's a laxative. Alright, so some of the things you could do, Kegel, is going to strengthen that pelvic floor muscle. You can use biofeedback here, assuming that they still have all the neuromuscular working. Obviously, biofeedback doesn't work very well if they're paralyzed. But Kegel strengthening that floor muscle, pelvic floor muscle, to contract those sphincters, because it might be that your internal sphincter is stronger than your external. So we're trying to balance that out and straighten up the other side of it. You also can have surgery. To correct those sphincters. Again, if you ripped it completely during childbirth, then that might be indicated. Another aspect, and is Celeste ACE acid gel. This is inserted into the subcutaneous area of the anus, and it literally closes off it. So it's almost like you're implanting something to close down that area, which is really creates a lot of concerns to me. But anyways, that's what that does. It's just basically narrowing the anal canal. Again, in the hopes of returning continence. So that is fecal incontinence. And again, you want to be watching your skin, eye, nose. But again, skin's going to be pretty important there. Fecal incontinence can have skin deterioration. Alright, so constipation. Obviously, this is the absence of stool. So I feel like I didn't hit that too much. So some of your processes is low fluid, low activity, lack of fiber, and again, stress. So low physical activity, opioids, ignoring the urge to go. So when people ignore that urge to go, then that's going to create issues. Stress, some diseases, and overuse of laxatives. So that really high constant use of laxative is actually going to create constipation, and that's because you use so many laxatives that there's no muscle tone left at all, and it creates constipation. So that a lot of times like overuse or abuse of laxative can be seen in people with eating disorders. But your treatment here, so stool softeners obviously, increase the fluid, increase the fiber, get them up and get them moving. Move. Alright, so increase those ADLs. And then you're still going to want fiber. So remember that fiber is used not only for not only for diarrhea, but for also constipation. Just it creates normalcy, I guess we could say. Alright, so your patient teaching is going to be obviously your nutrition aspect. That fiber increase is being done slowly. 30 quarts of water a day, so get that water in. Exercise, and then documenting a schedule of when they're going so that they know when they haven't gone for a week. Some people can't tell you that. And then again, avoid the overuse of laxatives because you're going to end up right back at the beginning again. As far as constipation goes. Constipation can lead you in obstruction, which is our next topic. Alright, so obstruction, intestinal obstruction, is basically where something can't pass for one reason or another through your the GI. So can't pass through GI. Alright, and there could be several reasons for this. There's mechanical and non-mechanical. Your non-mechanical reasons are going to be your mechanical. Let's start there. Your mechanical reasons: hernia, cancer, because of that, diverticulitis. Diverticulitis is going to create polyps, so it's going to narrow that passageway. Your surgical adhesion is where you have like a surgery and then literally you have the a part of your vital organs attaching to the cavity wall, and that obviously is going to create issues because it should not attach there. So adhesion is some abnormal attachment between vital organs and the cavity wall usually, or maybe the vital organs on another organ. Non-mechanical has to do with neuromuscular or vascular. Vascular is a lot less prevalent. So your neuromuscular paralytic ileus, and again this is absence of bowel sounds, or paralyzed bowels. And of course, if you went into surgery, then they might be non-functional for a little while, but we're talking about prolonged use here. And it interferes with, when you have valves not working for a prolonged period, it's going to interfere with blood supply. And obviously, if I've got, let's say I've got a portion of my intestines and I have a block right here of whether it be scarring, polyps, diverticulitis, which is close to polyps, some type of cancer, tumor, mass, anything that's going to block my passage. When I do this, start blocking this passage, this part is going to back up, and this part is going to start to collapse. Alright, so you have proximal increase in pressure and distal collapse of the bowels. This increased pressure right here is going to increase your capillary permeability. Basically, I'm shoving things out, and it's going to go into third spacing and your interstitial spacing, and that is going to greatly reduce the amount of fluid that you have, because again, you have tons of fluid going into your intestines where it should be absorbed. But anyways, so when you have increased When you have a blockage, you have increased pressure. When you have increased pressure on this side, it's going to push that water through the cells and into your interstitial space. And when you have fluid loss in your interspace, it means that you've lost fluid that would otherwise be circulating in your blood. Not only are you going to have edema, but you're also going to have a reduce in blood flow or hypovolemic issues from there. And of course, you can go into hypovolemic shock. And you're going to have a reduced or hypotension. Alright, so your symptoms here for intestinal obstruction is obviously going to be pain. Anytime you have distension like that, or pressure, it's going to equal in pain. But you have nausea, vomiting, distension. You might have projectile vomiting that contains bile. So bile hygiene is going to be really important, because basically, if it can't go out your body, it's going to start going back up the other way. You're going to start vomiting that bile. Alright, that creates several issues. One, you're going to have tissue destruction along the way, and two, you really need to do hygiene for mouth. So, pain, nausea, vomiting, projectile bile. You're looking also at distension and colicky. If you know like a colicky baby, but colicky might be another symptom. All right, so you're looking at CT scans, X-rays, any type of scope to go in there and see what's causing this. CBCs and white blood cells are going to be important if it's infectious or if you have some type of cutoff. Your hematocrit is going to be important. And this happens, your white blood cells are going to happen in strangulation. So basically, there's several different things that can happen. Let's erase some of this. Alright. There's several different ways that it can be blocked. You can have a polyp, you can have a cancer, you can have a tumor, you can have a hernia, you're going to have adhesion. But when you have a part of, and let's just draw this for a second, when you have a part of your intestines that's blocked by something, alright, one, you're going to have this part start to collapse. Alright, or two, you can have reduced blood flow to all of this area. Alright, so when you have reduced blood flow, or you have something where something tight is going around that specific area, you can have decreased blood flow. Obviously, decreased blood flow means that you're going to have strangulation, and that will equal death of that particular area in the GI system. And strangulation is going to result in high red blood cells. So keep these people NPO. You're probably having nasogastric tooth, and they're strictly monitoring those INOs. Sometimes it can be relieved on its own, again with more conservative methods. But if it's strangulation, it's surgery. You need to have surgery at that point. Otherwise, we're trying to handle it as conservatively as possible. Trying to see if we can't get it unstuck without going through the surgery. And again, polyps or a diverticulitis will block it. Anytime that you have reduced blood flow to that area, obstruction, cancer, or tumors, those are going to be things that you look out for obstruction. And again, strangulation is going to be your biggest thing. And then again, that fluid shift with hypovolemia being your complication. All right, and that summarizes the rest of chapter 43.